Okay, we're back. And we're going to talk about psychosis. Schizophrenia is the disease. It has to do with the brain chemistry and changes in the anatomy. Psychosis is the thought processes. It's not necessarily the actual brain tissue and neurochemical involvement. It's the processing of it. Psychosis can be associated as organic, which is dementia, delirium, which we'll talk about. Alcohol and trauma. Somebody is alcoholic, they're drunk. You know what that looks like. That is an organic psychosis when they're really lit. An inorganic or a non-organic would be the schizophrenia, and the mood disorders with psychosis. And I know we've talked about depression, especially like postpartum depression, unipolar depression, bipolar depression. If taken to the extreme, they can become psychotic. They can have hallucinations. They can have delusions with those disease processes. Schizophrenia is another non-organic presentation of psychosis. Okay, so psychosis deals with thinking, the emotion, communications, remembering, interpretation of reality, and behaving that's insufficient when they're psychotic. Epidemiology, it's 1% of the population that has psychosis. It's usually a self-limiting disorder. I think of depression with psychotic features. Someone who's so completely depressed, they are hallucinating. Oftentimes that will, as the depression, if it's a situational depression, if it lifts, as it's lifting, the psychosis will pass. In some cases, you can control the psychotic behavior, especially in schizophrenia. If you give the right meds, you can control the psychotic behaviors, and then they're in control. But there is some links in twin studies, no genetic links. It's probably the most pure schizophrenia is, but we're talking psychosis. Okay, so psychosis is different. Most of them use nicotine and some sort of extra substance. About 50% are depressed, and they're more violent. But if my reality was altered to the point that I didn't know what was true and what was not true, I think that I would probably be fairly violent also. I would be scared. And I think a lot of these people, when we say that they're violent, they're not inherently violent, but they're more frightened of what they're seeing and experiencing as a life event because it's not real. Other comorbidities, anxiety, psychosis-induced polydipsia is really interesting because you really can drink yourself to death. You can drink a lot of water, and then you can dilute your body, and it can kill you. And some drugs do that. I'm not sure which one. Ecstasy, meth. There's a few of them that could cause polydipsia, and then that can go into a psychosis, and then you have a psychotic polydipsia. Again, schizophrenia is different than psychosis. Psychosis is the presentation of schizophrenia. Schizophrenia itself, as a purist, has to do with the brain and the neurochemicals involved. They believe that there are problems with dopamine neurotransmitters, dopamine receptors. It just depends. It is familial. There is a genetic link to it. If you're interested in exact genetics, I think it's G72, G70. I'm not really sure. I'd have to look it up for you, but I would. Schizophrenia does run in families. They found linkages in twin studies. They found linkages in first-degree generation people. Some of the things that are different about the brain is the differences in the lower brain volume, larger ventricles, atrophy of the frontal lobe, which is responsible for impulsivity, more cerebral spinal fluid, and lower rates of blood flow and glucose metabolism to the frontal lobe. Again, the frontal lobe seems to be the most influenced by the dopamine problem that's there. And I want to come out and say dopamine in schizophrenia, the problem is varied. It's either too much dopamine available because of increased receptor sites, which they found on autopsy, or not enough dopamine available because of lack of production, possibly. Again, they're not really sure. But the symptomology of schizophrenia depends on if they have excess dopamine or not enough dopamine. And those symptoms are called positive symptoms or negative symptoms. And they're associated with positive being excess dopamine, negative being not enough dopamine. Okay. Other thoughts on it? They think it has possibly something to do with complications in utero, nutrition in utero, stress, use of street drugs. I don't think that those would present as an actual brain dysfunction more than a psychosis, again, which is a presentation. It's not an actual brain change. So, half of one, 6 dozen of the other. What is it? Half dozen of the other, 6 of one, half dozen of the other. That's the statement, I think it is. The DSM criteria for schizophrenia: hallucinations, delusions, disorganized speech, disorganized thought processes, behaviors, positive and negative symptoms, and some sort of dysfunction in society. When we meet Adam, and we're going to be meeting him coming up, he does the talk for me. He is schizophrenic. He is very functional. He's a high-functioning schizophrenic, which speaks to the differentiation. He's not psychotic. He's not ill in that way in behaviors. Yes, he has the disease. Yes, he'll always have the disease, but it's almost in a remissive state at this point for him. The A's of schizophrenia, and these are just some things for you to remember. Associative looseness, they usually have some change in their affect, and that's just their face. Ambivalence, apathy, autism. When I say autism, I don't mean autism as in the disease, but autism as in the separation of their personhood from reality or society in general. Their appearance is different. The attention is different. Amnesia, as in they forget things. They'll have lapses in memory. Alogia, that depends. Sometimes it's called thought blocking, where they actually will be talking right along and then they'll have no more language. It'll just be gone. So that's alogia. Agitation, evolution, the lack of volition to do anything, the lack of will to do anything. Auditory hallucinations, delusions. There's a big difference between hallucinations and delusions. Hallucinations attach themselves to the senses. So you can smell something, you can hear something, you can see something, you can taste something, you can feel something that's different than what everybody else around you is experiencing. Delusions is the false fixed belief. They believe they are Jesus Christ. They believe that they go golfing with the Pope because as a reward because they killed Hitler and they're only 22 years old. So how were they alive at that time? You think to yourself. But there's a difference. They are both considered, however, positive symptoms of schizophrenia, because when you're differentiating between positive and negative symptoms are things that have been added to the person. Negative symptoms are things that have been taken away from the person. So hallucinations and delusions, people usually don't have those as usual. So those things have been added to the personhood. So they're positive symptoms. The lack of volition, the lack of will to do anything, the blunt or the flat affect, those are things that have been stolen or taken away from the person. So those are negative symptoms. It's very difficult to differentiate between positive and negative symptoms if you can't find your own way of understanding it. This is how I understand it. If something's been added to the person, it's positive. If something's been taken away from the person, then it's negative. It works for me. Okay. Okay, again, we talked about hallucinations, auditory, visual, tactile, olfactory, gustatory. Now, I want to come out and I say, remember, we always have to rule out the physiological. So, if someone tells you they're tasting metal, or they're tasting like they're sucking on pennies, like they taste copper, that is a big sign of lactic acidosis. So if they're on glucophage, you probably ought to check that out. That's a legitimate concern. If they're not, then it could be a hallucination. But just remember, it's not just what you see and you hear. It's everything. It's all your senses. Delusions have some particulars. There's ideas of reference. Ideas of reference are kind of fun. Not for the person, I'm sure, but it usually involves a newspaper, involves some media. The person with schizophrenia believes that they are the center of all this media attention. Delusions of persecution, everybody's out to get them. Delusions of grandeur, they're very important. Delusions, somatic delusions. I always say it's my daughter on a day she has math exam. She has a tummy ache. Oh, I tell her to quit having her somatic delusions and get out of bed. These people, for schizophrenics, they believe that there's been something implanted in their body, and if they can dig it out, like a chip, a tracking device, in their arms or their legs or their torso, and if they can just dig it out, and so you might see them and they have been self-injurious, attempting to get in there, and that's a somatic delusion. Delusion of jealousy. This is great. I actually went in to see a schizophrenic patient. She was 69 and living in a nursing home with her husband, and she was very out of control. She was very deluded. She believed her husband was having an affair with the director of nursing. And she actually tried to start a fist fight with the director of nursing right in the middle of the hallway there when I came in to see her. So it usually has to do with the spouse. It's a false belief that they're being unfaithful. It doesn't have anything else to do with any other close relationships, which makes it very unique in its own. Needless to say, for this patient, after we did extensive discussion and we did a lot of medication adjustment, she came around, and fortunately we had to move the husband out of the room because she would be violent against him also. We were able to move him back into the room with her. So the positive symptoms, these are things that have been added: hallucinations, delusions, real bizarre behavior, formal thought disorders, and that is fixed false beliefs, paranoia due to increases in dopamine. So more dopamine, more sensory stuff. Negative symptoms, affective blunting, and you're going to get confused between blunting and flat. Affective blunting is kind of like the person who is in shock. They just can't believe what they just saw. Oh my God. And they're like that. And it's very minimal emotion. Affective flatness, there is nothing. I can't even do it. I've tried to simulate this for years, and I just can't. I can't even not animate my face. So, and hedonism, energia, and hedonism, they just don't care. Energia, they have no energy, no will to do anything. Oftentimes they'll have poverty of speech or poverty of thought, and it doesn't necessarily mean that it's poor. It's lacking. I've had several very high-functioning people, when they first started, very high-functioning people. Schizophrenia starts usually in young adulthood, so you're right there in the midst of where it's going to present, who were in law school or they were in some sort of university setting, and they were studying to be a doctor, and then all of a sudden everything's just gone. So they can still have a conversation with you, but what they once knew is missing. So that's what I mean by poverty of thought. The thought blocking, we've talked about it. Most of the time they're isolative. They don't want to interact, so that's going to influence their societal interactions, and that's due to a lack of dopamine. So positive symptoms, too much dopamine; negative symptoms, lack of dopamine. And that's going to dictate how we treat them, what medication we're going to give them to assist them to get more dopamine or take some away. They're easily distracted, impaired memory, poor problem-solving skills, poor decision-making skills, and all that's in the frontal lobe. Impaired judgment, right up here. Illogical thinking, and those are good due to decreases in dopamine too, and those are negative symptoms. Like I said, usually it presents early adulthood. It's not something that people get over. It doesn't ever go away. It's a chronic disease. It's with you for life. And oftentimes when it's first found, they have extensive positive and negative symptomology, and they need some sort of treatment right away. So we have to get them in. We have to get them started on medications, and they have to be on medications, and they have to maintain the medications. Schizophrenics, if they don't have good support, the problem is they're not going to take their meds. If they don't have a support system, if they don't have somebody who is there to give them what's real and to help them with what's real, you're going to lose them. I have schizophrenics that live under bridges in Dayton because they have no support system, but they know where it's warm, and they know where they live, and they know if they come and see me once a month, they're going to get a sandwich and a cup of coffee. And so they show up, and when they show up, we give them their antipsychotics. We give them an Invega shot. We give them Risperdal. We give them, there's one more, Invega, Risperdal Constant, Invega Mentena. It'll come to me. I'll get back to it. But they get the shot, and it lasts them 3 to 4 weeks before they come back in again. That can't go on forever, them living under a bridge. It can't. What are we supposed to do with that? I don't know. I wish I had some ideas of what to do with that. We just do the best we can for right now, I suppose, until we get more community health centers opening up to take care of these people who are out there. We need to maintain them on their meds. We need to make sure that they don't relapse. And that being said, it's easier said than done, because just like any chronic disease, relapse is going to happen. Medications, after a while, maybe it worked for 4 weeks and now it only works for 3 weeks, and then they forget to come see me. I can't go out and look everybody down. I can't search them down. What are you going to do? Well, call the police station, have them check around, see if they find the person, get them into you, change the medications. Even Adam has had some trouble. A couple of years ago, he wasn't able to come talk to the students because he actually had a need for a recalibration of his medications. So even though we have them on meds, and even though we have them somewhat controlled, over time they may not always work forever. So we need to bring them in. We need to do a history. We need to get worked up. Any physical comorbidities. We need to make sure they're safe. Look at all their medications, their compliance, and their support systems. They're going to have alterations in sensory perceptions. They're going to be isolative. They could be violent towards themselves, but inherently they're not violent towards others unless they feel paranoid. And then it's a self-preservation thing. It's not I'm going to kill you because I want to kill you. It's more, I'm going to kill you before you kill me kind of thing. Lots of self-care deficits, lots of inappropriate, ineffective coping with families. Families have to realize that they did not do this to their son or daughter, which is a big thing because they feel guilty. It's something they did. It's not something they did. It just happens. We have to be calm. We have to be accepting. We have to keep promises. We have to make them trust us. Do not touch them. Don't. It's just not a good practice, because that involves, we want to, as individuals, offer a gentle hand for therapeutic touch to let them know that we care about them as individuals. When you touch them, it can burn. When you touch them, they now have a disease. Their thought processes are off. So just don't lay hands on them. It'll be difficult, but you're going to have to. You can't whisper, you can't laugh where they can see you or hear you. Don't be getting on the computer right after you talk to them if they're paranoid, because when you're doing that, you're reporting to the government on them. So don't do that. If they do positive things, if they're more reality-based, they're more insightful, which is another word, you want to reinforce that behavior. That's very insightful of you. That's really, really wise. I'm glad you noticed that. Things like that. One-on-one until you get them under somewhat control. And then they can go to groups. But even then, remember the perceptions are going to be off. And you have a lot of different diagnoses in this group that could feed off of each other and cause some problems. So for hallucinations, again, it all goes back to trust. If they trust that you're the real thing and not this other thing that they're seeing or hearing, they're going to talk to you, and you want them to talk to you. You want them to tell you what they're hearing. You want them to tell you what they're seeing, and that they know it's not real. That's what you want to hear. You want to allow them to describe it to you. And if somebody is hearing things, you want to know what it's saying. Is it a command hallucination, or is it just somebody whispering to them, and maybe they can't make it out? Command hallucinations are very dangerous. Command hallucinations often will say, kill yourself, kill yourself, kill yourself, or take a gun and shoot the school, take a gun and shoot your neighbor. Those are command hallucinations. They're trying to tell the person to do something. Medication quiets the voices. I've been told that it doesn't make them go away, but rather it makes them like an incessant kind of buzzing that they still hear, but they can't make out what's being said. That's okay. Command hallucinations, usually they're on suicide precaution, and then you don't go into their rooms when you're doing that, because they could hurt you. Communications with delusions, be very matter of fact about it. Present reality. If they say they're walking up down the hallways and they're like, there's this person that's following me, say to them, you and I are the only two people in this hallway, and I don't see anybody following you. Reality, present it. I believe that you believe it, but it's not real. Okay, so you got to be open and honest, matter of fact. Listen to them. Don't argue with them. If they say something like, I am God, I am the mother of God, my mother died before I was born, you can inject some doubt into that. I can heal all sorts of things. Well, don't you think that'd be kind of unusual for someone to have that kind of power to do that? So that's like an interjecting doubt. It helps them come back to reality. Redirect off the delusion, whatever you do. That one woman was just so identified with fungus. You just have to redirect. And sometimes you have to just be blunt and say, I'm sorry, I need to go now, and walk away. Associative looseness, don't pretend you understand it. I don't understand it. And I'll say, I'm sorry, I don't understand what you're saying. So do that. Place the difficulty on understanding on yourself. I'm sorry, I don't understand what you're saying. So I'm putting the problem with me, not with them. Look for recurring topics and themes. Emphasize what's going on in the client's environment. Reality-based activities, communications should be clear. I think that this television show is a little loud right now. Turn it down. Possibly it's like Law and Order, and now they have this delusion that they are part of the scene that's going on in Law and Order, and they are the person who's killing everybody. Turn the TV down. Redirect them to some sort of reality-based activity. Bring them with you. Come help me pass out orange juice. Something like that. Inappropriate behaviors on the part of the nurse. You are not his mother. You are not there to protect him from everybody else or defend him. Okay? You are not there to protect the other patients. I mean, you're there to protect the other patients, yes, for their safety, but not to the point where if he walks into a room and sits down beside someone and doesn't do anything or say anything, that you immediately remove this other person. That's an overreaction. Don't do that. Distracting is often a good thing to use. Like if they're fixed on a delusion and they're going on and on and on about it, you can say, come over here, let's do this. Or what did you do in art today? Get them off topic. That's helpful. You don't want to get to the point that you're doing that all the time, though. And remember, we treat them with respect, regardless of who they are, what they're about. Unconditional positive regard. This is a person, and we respect their personhood. Communication with someone who's paranoid, be honest. Don't whisper, don't laugh, don't get on the computer. Teaching, learn all you can about the disease processes and share it. Develop a relapse prevention plan. Help them comply with treatment, help them get off of drugs and alcohol. Do your best to get them somebody in their support system, somebody who's going to be in their corner. For some other people, it's easier than others. Antipsychotic drugs, there's a lot of medications out there that are really nice for psychosis, and they're called antipsychotic drugs. They also are used in schizophrenia, okay, because oftentimes schizophrenics present with psychosis. Okay, so we have traditional. Most of them are oral, and that's Thorazine, Haldol, stelazine, and Mellaril. I see Thorazine most often, and Haldol. I hate Haldol, but it's an antipsychotic. It's one of the oldest ones that's out there. And it looks like somebody's coming in.